Hematology Chapter 5 Microcytic Anemias. Anemia is a reduction in the mass of circulating red cells. Anemic red cells are no longer able to supply oxygen to the body tissues. Classification of anemia. Physiology, based on symptoms and bone marrow response. Morphology is based on red cell indices. Normal red blood cell indices are the mean corpuscular volume, or MCV, mean corpuscular hemoglobin, or MCH, and mean corpuscular hemoglobin content, or MCHC. Microcytic hypochromic anemia is hemoglobin synthesis is disrupted. MCV is less than 80 and MCHC is less than 32%. Microcytic anemias. Iron deficiency anemia, sideroblastic anemia, which can be acquired and inherited, thalassemias, and anemia of chronic disease. Iron intake and absorption. Iron ingestion, iron absorbed from intestinal mucosa, iron incorporated into hemoglobin using recycled or new iron, iron stored as ferritin and hemosiderin, iron lost through blood loss and other sources. Iron analysis. Total iron binding capacity, or TIBC, measure of transferrin. Serum iron, measure of iron in serum. 95% of iron is complexed with transferrin. Unsaturated iron binding capacity. Reserves transferrin, not bound to iron, but capable of binding. Iron is transported from the intestine attached to transferrin. Most iron is delivered to the bone marrow. Excess iron is deposited in the tissue for storage. Ferritin, primary storage compound. Cannot be seen by microscopy. Does not stain with iron stain. Indication of iron stores. Apoferritin is ferritin without iron. Hemosiderin, aggregate of protein and iron. Sideroblasts, siderocytes, and macrophages. Appears as yellow to brown refractile pigment. Prussian blue stain appears as blue intracellular particles. Iron is absorbed in the gastrointestinal tract and transported into circulation. Iron storage and recycling. Storage. Ferritin is measured in plasma. Hemosiderin is identified in urine or in stained bone marrow slides. Resides in liver, spleen, bone marrow, and skeletal muscle. Recycling. Iron is removed from circulation by macrophages and the spleen, liver, and bone marrow. 95% of recycled iron is used for red cell production in an adult. Lab assessment of iron. Serum iron. TIBC is a measure of transferrin. Measurement based on the amount of iron that can be bound. Percent saturation of transferrin. Serum ferritin. Iron deficiency anemia. Slow GI bleeds and excessive uterine bleeding over time leads to depletion of iron stores, resulting in IDA. Seen in infants, pregnant or nursing women, and young children, because the growth rate and development can outstrip the iron intake. It can cause GI bleeding for men or excessive menses for women. Pathophysiology. Microcytic hypochromic. Red cells are small and deficient in hemoglobin. Red cells show diminished erythropoiesis as hemoglobin synthesis is disrupted. Small red cells have less ability to fulfill heme requirements. CBC shows decreased red cells, hemoglobin, hematocrit, MCV, and MCHC. Increased red cell distribution width. Development of IDA. Stage 1. Continuum of iron depletion from the marrow. Prussian blue stain shows absence of iron. Stage 2. Iron deficient erythropoiesis and slight microcytic hypochromic picture. Stage 3. Fully developed case of IDA in the peripheral circulation, microcytes, and hypochromia. Symptoms. Most cases do not present with overt symptoms until stage 3. Fatigue, pallor, vertigo, dyspnea, cold intolerance, and lethargy. Cardiac problems such as palpitations and angina. Pica, or abnormal craving for unusual substances such as dirt, ice, or clay. Chapping around the edges of the mouth. Spooning of the nail beds. Laboratory findings. Serum ferritin at all phases. Serum iron. Microcytic hypochromic red blood cells, possible target cells, and elliptocytes. Transferrin, total iron binding capacity, and transferrin saturation. Bone marrow. Mild erythroid hyperplasia, increased cellularity, ineffective erythropoiesis, no significant increase in reticulocytes. Ragged cytoplasm of red blood cell precursors. No sideroblasts, siderocytes, macrophages with iron. Decreased ferritin. Decreased serum iron, increased TIBC. The treatment is supplemental iron. Anemia of chronic disease, the most common anemia of hospitalized populations. The clinical picture: normocytic normochromic to microcytic hypochromic. Occurs in association with chronic disorders, such as chronic inflammatory disorders, chronic infections, and malignant disorders. Characterized by low serum iron, but normal iron stores. Iron studies. Serum iron is decreased. TIBC is decreased. Decreased siderocytes and sideroblasts. Ferritin is increased. Adequate iron stores, or iron in histiocytes. Pathophysiology. Faulty heme synthesis. Impaired marrow response to anemia. Cytokines inhibit erythropoietin production. Block in iron release from macrophages. Defective release of iron from macrophages to red blood cells. Sideroblastic anemias. Related to mitochondrial overload. Inherited or acquired. Iron accumulation leading to the presence of iron debris in the red cell precursors in the marrow, or ringed sideroblasts. Symptoms are splenomegaly, increased ferritin, increased protoporphyrin, acquired through alcoholism, chloramphenicol, copper deficiency. Pathophysiology. Disturbance in enzymes regulating heme synthesis. Ringed sideroblasts are formed due to an accumulation of iron in the mitochondria that circle the nucleus of the red blood cell. Mitochondria rupture when they fill with iron. Normal red blood cells have iron deposited evenly throughout the cytoplasm. Blood smear. Microcytic hypochromic anemia. Dimorphic blood picture. Pappenheimer bodies. Faulty erythropoiesis. Hereditary hemochromatosis, or congenital iron overload. Genetic disorder, almost always a diagnosis of exclusion. Diagnosis is usually made incidentally as a result of screening for an unrelated issue. The transferrin receptor in the normal iron delivery process does not bind properly. Iron is constantly loaded into storage sites and leads to multi-organ damage. Symptoms: chronic fatigue, cirrhosis of the liver, hyperpigmentation, diabetes, impotence, sterility, cardiac arrhythmias, tender swollen joints, hair loss, and abdominal symptoms. Screening for iron status: serum iron, serum transferrin level, TIBC, transparent saturation. Iron, ferritin, and transferrin saturations are elevated. TIBC and ferritin are normal. Treatment: aggressive therapeutic phlebotomy or bloodletting. The goal is to reduce serum ferritin levels to less than 10 micrograms per dl and keep the patient's hematocrit around 35%. For patients who are unable or unwilling to do therapeutic phlebotomy, deferoxamine, an iron chelating drug, can be used. Iron will be excreted in the urine. Anemias caused by abnormal heme production are lead poisoning and porphyrias. Lead poisoning is found in children eating lead-based paint from painted items. Lead was removed from paint in 1978. Clinical picture in children: hyperactivity, low IQ, impaired growth and development. Effect of lead on red blood cells: lead accumulates in red blood cells and inhibits heme synthesis, causes basophilic stippling. Diagnosis was increased lead level in the blood. Lead affects enzymes in heme synthesis. It blocks delta aminolevulinic acid to porphobilinogen. This blocks addition of iron to protoporphyrin, which means an increase in delta aminolevulinic acid and an increase in protoporphyrin. Porphyrias, a group of inherited disorders, characterized by a block in porphyrin or heme synthesis. Defect in enzymes in heme synthesis. Block in heme synthesis results in accumulation of porphyrins in tissues and in urine and feces. Port wine-colored teeth, red urine. Symptoms are photosensitivity, abdominal pain, and neuropathy. Thalassemia first described: anemia, hepatosplenomegaly, skin discoloration, jaundice, peculiar facial features, bone changes, bone marrow erythroid hyperplasia, PB, many nucleated red blood cells, target cells, and microcytes. Thalassemias: beta thalassemia major and minor, alpha thalassemia major and minor. Microcytic processes with nothing to do with iron. It is a globin chain disorder that results from lack of production of alpha or beta chains. Pathophysiology: microcytic has nothing to do with iron. Globin chain disorders resulting from lack of production of alpha or beta globulin chains. Defects of hemoglobin synthesis. Anemia develops with microcytic cells. Abnormal red cell morphology and multi-organ complications. Major thalassemias. Alpha, result from alpha gene deletions. Beta, defective beta gene. BO individuals, complete lack of synthesis of beta chain. B plus individuals have limited amount of beta chain synthesis. Alpha thalassemia has a high incidence in Asian populations. Alpha globulin chain issues. 4 clinical states: Barrett's hydrops fetalis, hemoglobin H disease, alpha thalassemia trait, and silent carrier. Barrett's hydrops fetalis. Total absence of alpha chain synthesis. No hemoglobin A, no hemoglobin F, only hemoglobin Barrett's. Anemia is severe, usually leads to stillbirth or spontaneous abortion. High affinity for oxygen, does not deliver to tissues, not compatible with life. Babies that are born have generalized edema, pleural and pericardial effusions, and severe hypochromic anemia. Hemoglobin H disease. 1 functional alpha gene. Other 3 genes are deleted. Small amounts of hemoglobin A are produced. Hemoglobin H is formed. Variable splenomegaly and bone changes. Hemoglobin averages under 10 grams per dl. Reticulocyte counts 5 to 10%. PB smear shows microcytic hypochromic red blood cells with red cell fragments. Brilliant crescent blue shows hemoglobin H inclusions, or a pitted golf ball. Less severe alpha thalassemia. Alpha thalassemia trait, 2 gene deletion state. 2 viable hemoglobin A genes. Some Barrett's hemoglobin is formed. Microcytic hypochromic cells. Mild anemia. Silent carrier, 1 gene deletion state. Hematological, normal, or slightly microcytic. Diagnosis and treatment. Bites hydrops fetalis, treated with amniocentesis. Molecular diagnostics, pregnancy terminated. Severely endematous fetus not viable are delivered. Cord blood tested for hemoglobin electrophoresis. Hemoglobin H. Elevated red blood cell combined with extremely low MCV under 60 FL. Misshapen red cells and cell fragments. Transfusions given when necessary. Alpha thalassemia trait. Mild anemia. Many microcytic hypochromic cells. Some hemoglobin Bartz is formed. PP elliptocytes in target cells. Silent carrier. Hematologically normal to slightly microcytic. Elliptocytes and target cells. Beta thalassemia major. Cooley's anemia. Mediterranean anemia. Inherited. Little or no beta chain is synthesized. Little to no hemoglobin A is synthesized. Affects multiple organs, quality of life, and longevity. First 6 months, no issues because hemoglobin F. 2 to 4 years of age, children fail to thrive. Irritability, enlarged spleen, symptoms of anemia, jaundice, and transfusions required. Living with multiple health issues, severe anemia, hemoglobin values 6 to 9 grams per DL, PB, severe microcytic hyperchromic process. High number of nucleated red blood cells, marked polychromasia, high degree of red blood cell morphology. Chronic anemia state. Overexpansion of the capable BM. Quality of bone is thin and fragile. Fractures and bony changes in facial structure. Spleen reaches enormous proportions. Excessive hemolysis and discomfort. Absorb more iron through diet to try and accommodate for increased EPO. Treatment. Splenectomy, transfusion regimen, bone marrow transplantation, stem cell transplant. Concerns for iron overload. Assess liver, pancreas, endocrine, and cardiac iron. Iron chelation. Ferritin level reaches 1,000 micrograms per liter. Thalassemia minors. Thalassemia intermedia. Develop problems later in life. May not need transfusions. Bone changes may be mildly present. Beta thalassemia trait. Only one abnormal beta gene. Mimics IDA. Microcytic hypochromic. Moderately low H&H. Hemoglobin A2 5 to 10%. Increases red blood cells. Increased EPO. Chapter 5. The microcytic anemias from the book. Word key. Anemia. A reduction in the mass of circulating red blood cells. Chelation. Procedure to remove a heavy compound such as a heavy metal, frequently performed in patients with iron overload. Collagen vascular disease. Disorder that affects primarily the joints and mobility part of the connective disease spectrum. Dyspnea. Shortness of breath. Gastrectomy. Removal of a portion of the stomach. Jaundice. Yellow discoloration in mucous membranes of the eyes and yellow tone to the skin resulting from increase in bilirubin. Menorrhagia. Excessive menstrual bleeding. Senescence. In hematology, the end of a normal red blood cell's lifespan. Serum ferritin. Iron stored in the spleen, liver, and bone marrow. Vertigo. Dizziness. Introduction. Individuals become anemic when their red blood cells are no longer able to supply oxygen to their body tissues. Anemias may be classified according to their physiology or their morphology. The morphologic classification is based on red blood cell indices, whereas the physiologic classification is based on symptoms and bone marrow response. If a microcytic hypochromic anemia develops, hemoglobin synthesis is disrupted. The MCV is less than 80 FL and the MCHC is less than 32%. The red blood cells are termed microcytic hypochromic because they are small cells that are deficient in hemoglobin, indicating the low MCV and MCHC. Microcytic anemias are caused by iron deficiency anemia, sideroblastic anemias, acquired and inherited, thalassemias, and a percentage of anemias of inflammation or chronic disease that transcend into IDA. Iron intake and iron absorption. Iron is one of the most abundant metals in the world, yet IDA continues to be one of the most prominent nutritional disorders worldwide. Iron balance is regulated by several conditions, which include amount of iron ingested, amount of iron absorbed from intestinal mucosa, the duodenum and upper jejunum, amount of iron incorporated into hemoglobin using recycled or new iron, amount of iron stored as ferritin and hemosiderin, iron loss through blood loss or other sources. The amount of iron that must be obtained through the diet varies according to age and gender. Men and infants should absorb about 1 milligram a day. Premenopausal women should absorb about 0.2 to 2 milligrams per day, and children should absorb about 0.5 milligrams per day. For perspective, if a man eats a 2,500 calorie diet, he ingests about 15 milligrams of iron, of which only 10% is absorbed, giving him 1.5 milligrams per day of iron that can be used for red blood cell production or stored in the reticuloendothelial system. Iron in the diet is available as heme iron through meats or as non-heme, non-meat iron, which is found in beans, clams, and vegetables. For an infant, iron-fortified formulas and breast milk are major sources of iron. As an infant develops and rapidly gains weight, there is a high demand for iron. Most infants and young children need some dietary supplementation to maintain iron balance. Additionally, menstruating and pregnant women have an increased iron need. When iron is absorbed, stomach acid converts the iron molecule from the ferric state to the ferrous state, and iron molecules are transported to the small intestine. Iron molecules are reconverted back to the ferric state and are carried through the circulation to the bone marrow via transferrin. Transferrin, the transport vehicle, is a plasma protein formed in the liver that assists iron delivery to erythroblasts and pronormoblasts in the bone marrow or for storage in the marrow, liver, or spleen. Transferrin receptors on the pronormoblast bind iron so that iron molecules can immediately begin incorporation into the heme molecule and protoporphyrin during erythropoiesis. The ability of the transferrin receptor to bind iron is influenced by the iron being delivered, the pH of the body, and, on the molecular level, the influence of an iron regulatory factor, ferrin repressor protein. An essential ingredient for seamless iron absorption and transport in a healthy GI tract. Procedures such as gastrectomy or gastric bypass, atrophic gastritis, and celiac disease may compromise iron absorption. Conditions such as ulcerative colitis, celiac disease, and irritable bowel syndrome may also impair iron absorption. Additionally, there are dietary substances that enhance or diminish the absorption of iron from the diet. Iron storage and recycled iron. Ferritin and hemosiderin are the primary storage forms of iron. These compounds reside in the liver, spleen, bone marrow, and skeletal muscle. Ferritin can be measured in plasma, whereas hemosiderin is most often identified in the urine or in stained bone marrow slides. In men, iron stores are generally 1 to 1.4 grams of body iron. In women, iron stores are generally 0.2 to 0.4 grams. Given these figures and with the realization that the iron absorption requirement is on average 1 milligram a day, it's easy to understand why anemia may take years to develop in adults with iron-poor diets. Specifically, body stores in men of 1 gram would last 3 to 4 years before iron depletion occurs. For this reason, most cases of iron deficiency relate directly to external blood loss, especially menorrhagia or slow GI bleed. Iron lost outside the body has no chance of being recycled into the usable byproduct of heme and globin. The recycling of iron after the natural cell death or senescence of aged red blood cells is an efficient process. Senescent red blood cells are removed from the circulation by the macrophages of the spleen, liver, and bone marrow in a process termed erythrophagocytosis. The ferrous form of iron is removed from hemoglobin and distributed to the macrophages, and the amino acids of the globin chain are returned to the amino acid pool. Subsequently, each of these products later is recruited for future hemoglobin formation and red blood cell production. In an adult, approximately 95% of recycled iron is used for red blood cell production, whereas in an infant, only 70% is used for this purpose. Consequently, it is essential that dietary iron is available for infants because 30% of dietary iron is necessary for hemoglobin production. Because of this relationship, it is easy to understand the significance of adequate iron sources during early years of development. Iron deficiency anemia. There are populations that are vulnerable to IDA. Infants and pregnant or nursing women may have nutritional deficiency. Young children may develop IDA when their growth and development rate outstrip their iron intake, and young women who have increased iron need because of menstruation may develop IDA. The primary cause of iron deficiency in the Western world is GI bleeding for men and excessive menses for women. External blood loss presents a significant challenge to the body because millions of shed red blood cells can never be used for recycling new red blood cells. Slow GI bleeds and excessive uterine bleeding over time lead to a depletion of iron stores, resulting in IDA. Additional causes of iron deficiency are impaired absorption of iron, medications, chemotherapy, surgical bleeds, and chronic disease, which damages iron mechanics. Barring any other external loss of blood, iron deficiency solely resulting from lack of dietary sources would develop over a protracted period. Box 5.2 Causes of iron deficiency anemia. Related to increased iron demands are growth spurts in infants and children, and pregnancy and nursing. Related to lack of iron intake is poor diet and conditions that diminish absorption. Related to blood loss is menorrhagia, gastrointestinal bleeding, hemolysis, and other physical causes of bleeding. Box 5.3 Stages of iron deficiency anemia matched to diagnostic signals. Stage 1. Iron stores depleted. You would test for absence of stained bone marrow iron, decreased serum ferritin level, increased total iron binding capacity. Stage 2. Iron deficient erythropoiesis. You would test for slight microcytosis, slight decreased hemoglobin, and decreased transferrin saturation. In Stage 3, iron deficiency anemia, you would test for decreased serum iron, decreased serum ferritin, increased total iron binding capacity, and decreased transferrin saturation. Pathophysiology and symptoms. IDA manifests as a microcytic hypochromic process in which the red blood cells are small and deficient in hemoglobin. Iron-starved red blood cells show diminished erythropoiesis as hemoglobin synthesis is disrupted owing to iron scarcity. Small red blood cells result with less ability to fulfill heme, iron, and protoporphyrin requirements. The complete blood count is characterized by a decreased red blood cell count, hemoglobin, hematocrit, MCV, and MCHC, and increased red blood cell distribution width, owing to variation in size within the red blood cell population. The development of IDA is a three-stage process. Stage 1 is the continuum of iron depletion from the marrow. Prussian blue stain shows an absence of iron. Stage 2, iron deficient erythropoiesis and slight microcytic hypochromic picture. Stage 3, fully developed case of IDA in the peripheral circulation, microcytes, and hypochromia. In most cases, the patient does not present with overt symptoms until anemia develops in Stage 3. However, serum ferritin decreases at every stage. IDA can be a secondary condition resulting from blood loss or inadequate iron intake. It may also be a secondary condition caused by a disease process or conditions that deplete iron stores, such as GI bleed or pregnancy. The physician may use diagnostic lab tests such as serum iron and serum ferritin to diagnose IDA well before the patient develops anemia. Individuals in high-risk groups should be monitored periodically for iron status. Many symptoms mark an individual as being iron deficient. Some of these symptoms are unique to iron deficiency, and some are general symptoms of anemia. Clinically, a patient with anemia may present with the following: fatigue, pallor, vertigo, dyspnea, cold intolerance, and lethargy. Additionally, patients may experience cardiac problems such as palpitations and angina. Symptoms unique to a patient with IDA include pica, or abnormal craving for unusual substances such as dirt, ice, or clay, cheilitis, or chapping around the edges of the mouth, and koilonychias, or spooning of the nail beds. Additionally, evidence suggests that iron deficiency in infants and young children may result in developmental delays, psychomotor impairment, poor immune function, and behavioral disturbances. In pregnant women, iron deficiency in the first 2 trimesters may lead to an increase in preterm delivery and an increased likelihood of delivering a low birth weight infant. Sensitivity to the possibility of iron deficiency, backed by good diagnostic data, is the best weapon for eliminating IDA in the Western world. More than 30% of the population has anemia. Iron deficiency accounts for a significant percentage of anemia. Symptoms such as weakness, ice cravings, excessive menstrual bleeding, and cold intolerance provide the first alert to possible iron deficiency. Tests used to help diagnose iron deficiency. From a clinical standpoint, if iron deficiency is suspected, analysis should include assessing the patient's red blood cell status and iron status. In terms of the CBC, all parameters except the white blood cell count and platelet count are less than the normal reference range. In some cases, such as if a patient is actively bleeding, the platelet count is elevated, and this is termed reactive thrombocytosis. MCV and MCHC are markedly lower than normal. RDW may be mildly elevated, and peripheral smear shows microcytic red blood cells that are hypochromic. Target cells and elliptocytes may occasionally be seen. The reticulocyte count is decreased compared with the level of anemia, indicating a slightly ineffective erythropoiesis. Tests that assess a patient's iron status include serum iron, serum ferritin, transferrin, or total iron binding capacity, and transferrin saturation. Serum iron is a measure of the total amount of iron in the serum, with a normal value of 50 to 150 micrograms per liter. Serum ferritin is one of the most sensitive indicators of iron stores, with a normal value of 20 to 250 micrograms per liter for men and 10 to 120 micrograms per liter for women. Ferritin is also an acute phase reactant, and conditions such as chronic inflammation or chronic infection may falsely elevate the serum ferritin level. In these cases, an accurate assessment of iron stores can prove difficult. TIBC measures the availability of iron-binding sites on the transferrin molecule. If an individual is iron deficient, there should be many binding sites available on transferring iron to bind, causing the TIBC value to increase. This value is elevated in iron-deficient patients, but subject to fluctuations in patients who use oral contraceptives or have liver disease, chronic infections, or nephrotic syndrome. TIBC is less sensitive to iron deficiency and must be evaluated in terms of the patient's other health issues. Transferrin saturation, or percent saturation, is derived as the product of the serum iron concentration divided by the TIBC and multiplied by 100. The normal value is 20 to 50%. Additional but lesser known tests that are available to measure iron status are the immature reticulocyte fraction assay and the reticulocyte hemoglobin content assay. IRF assay provides information on the ratio of immature reticulocytes to total reticulocytes in a blood sample. The RET-He assay refers to the quantity of hemoglobin in the reticulocyte and serves as an early indicator of available iron in the bone marrow. These parameters are available on Sysmex hematology instrumentation and are useful in measuring the marrow's response to iron treatment. Occasionally, a diagnosis of IDA is made too casually and is based on a patient's age group, gender, or vague complaints. Young women who give a history of fatigue or menstrual problems are often simply given a trial of iron therapy with no supporting laboratory workup. A diagnosis of IDA should be made only with supporting laboratory data that reflect the patient's red blood cell and iron status. The patient should insist that this work be done before therapy is initiated, as unnecessary iron use has the potential for serious consequences. Treatment for iron deficiency. Treatment for iron deficiency is given orally in the form of drops, which are good for infants and children, or tablets. Iron preparations are in the form of ferrous sulfate, ferrous gluconate, and ferrous fumarate at 325 milligrams in oral preparations, and iron by infusion for more serious cases of iron loss. Dosage, preparations, and time frame for iron are dependent on age, conditions, and patient compliance. Oral iron tablets are readily available over the counter in most places. Side effects from oral iron therapy include constipation, stomach discomfort, and diarrhea. Most side effects can be overcome with consultation from the pharmacist for a gentler preparation. It is essential for the patient to remain compliant and to continue on iron therapy despite side effects. Lab evaluations such as CBC, reticulocyte counts, and ferritin should show marked improvement in a few weeks. Additionally, microcytosis and hypochromia seen in the peripheral smear eventually are replaced by normocytic and normochromic red blood cells. Although oral iron normalizes the hematologic picture, an investigation should begin to identify the source of anemia and whether there are any underlying causes that are contributory. Some conditions leading to anemia of inflammation or anemia of chronic disease are rheumatoid arthritis, chronic renal disease, thyroid disorders, malignancies, inflammatory bowel disease. Anemia of chronic disease and inflammation, pathophysiology, diagnosis, and treatment. The anemia of chronic disease or the anemia of inflammation is one of the most common anemias in hospital populations and second only to IDA in terms of frequency. Many individuals with chronic disorders such as collagen vascular disease, chronic kidney disease, thyroid disorders, and malignancies may have an anemia that eventually develops into a microcytic anemia. When this occurs, most physicians order laboratory testing to establish whether there is also an iron deficiency process. This is termed differential diagnosis. Differential diagnosis is a process by which a physician examines a group of laboratory values and symptoms and tries to correlate them to a particular physiology. Patients with anemia of chronic disease show borderline low red blood cell hemoglobin and hematocrit, slightly low MCV, and normal MCHC. The peripheral smear is essentially normal with slight variation in size and chroma. Serum iron is low, serum ferritin is normal or increased, and serum TIBC is decreased. Although this is not the profile for patients with IDA, patients have low serum iron in both conditions. Several theories account for these data. In anemias of inflammation, iron is blocked from reaching erythroid precursors because of impaired release from macrophages. There is impaired erythropoietin production, and the pronormoblasts are not as responsive to EPO from patients with chronic disease. Few individuals require a blood transfusion for treatment of anemia. Usually, when the underlying disease is successfully managed, symptoms of anemia seem to resolve. Hepcidin, a normal hormone produced by the liver, regulates iron absorption from the intestines and splenic release of iron. This hormone is influenced by inflammation, hepatic iron erythropoiesis, and oxygen tension. If hepcidin is deficient, iron absorption is increased. increased hepcidin levels may restrict iron recycling. The expanding understanding of the role of hepcidin in iron metabolism will undoubtedly have exciting testing implications in the future. Sideroblastic anemias. The disorders in this category of anemias are related to mitochondrial overload. They are either inherited or acquired. Sideroblastic anemia is caused by iron accumulation leading to the presence of iron deposits in the red blood cell precursors in the marrow, called ringed sideroblasts, a dimorphic blood picture, and faulty erythropoiesis. Inherited sideroblastic anemia is X-linked or autosomal recessive. If X-linked, mutations appear in the 5-aminolevulinate synthase 2 gene. The autosomal recessive inheritance causes mutations in the SLC25A38 mitochondrial transporter gene. Over time, laboratory tests show a microcytic hyperchromic anemia with splenomegaly, increased ferritin, and increased protoporphyrin. More commonly, sideroblastic anemias result from acquired conditions, such as alcoholism, isoniazid, chloramphenicol, and copper deficiency. Additionally, a sideroblastic anemia is noted with one other myelodysplastic condition, refractory anemia with ringed sideroblasts. In any case, the patient's peripheral smear shows a microcytic process with dimorphism, or some microcytes and some normal cells, some hyperchromic and some normochromic, and the presence of Pappenheimer bodies, red blood cells with precipitated iron inclusions that look like grape clusters in the periphery of the red blood cell. An iron profile reveals increased serum ferritin and increased serum iron. As can be expected, when the underlying conditions successfully managed, the iron overload conditions are resolved. Hereditary hemochromatosis, or congenital iron overload. Hereditary hemochromatosis, or HH, is a genetic disorder in persons with European ancestry. More than 1 million people are affected in the U.S. Caucasians, African Americans, and Hispanics are particularly at risk. This disorder has a low profile relative to other blood disorders, however, partially because it is almost always a diagnosis of exclusion. HH is an autosomal recessive disorder carried on chromosome 6 that is closely linked to HLA-A3. It may be inherited homozygously or heterozygously, with homozygotes more prone to iron overload. However, signs of excessive iron loading are also present in 10% of heterozygotes. Because of this inheritance, individuals with HH begin to load iron excessively from a young age and continue iron loading with every decade. The diagnosis of HH is made incidentally in most individuals as a result of blood screening for an unrelated issue. In these individuals, the customary process of iron absorption and storage becomes unbalanced because of the inheritance of HFE, an abnormal gene that regulates the amount of iron absorbed from the diet. Two mutations, C282Y and H63D, have been described. Although the complete role of these mutant variations in the HFE gene is not fully understood, it is known that the normal product of these genes does not bind to the transferrin receptor in the normal iron delivery process. As a result of this faulty mechanism, iron is constantly loaded into the storage sites and leads to multi-organ damage and symptoms over decades. Iron accumulation is a multifactorial event, starting from iron excess with few symptoms and progressing to full-blown iron accumulation in tissues and tissue damage. It is important to remember that aside from this inherited condition, hemolytic process such as sickle cell disease and thalassemia, in which frequent transfusions are necessary, may also lead to iron overload as a secondary condition. Symptoms and laboratory diagnosis of hereditary hemochromatosis. HH is a great impersonator and has a myriad of symptoms that usually serve to confuse rather than lead to a direct diagnosis. The more common symptoms include chronic fatigue and weakness, cirrhosis of the liver, hyperpigmentation, diabetes, impotence, sterility, cardiac arrhythmias, tender swollen joints, hair loss, and abdominal symptoms. Each of the previously listed symptoms alone could point a physician in the direction other than HH. Yet, when these symptoms are combined with a microcytic process, a screening for iron status provides relevant information. As has already been indicated, screening for iron status includes serum iron, serum transferrin level, TIBC, and possible transferrin saturation. In patients with HH, serum iron, serum ferritin, and transferrin saturation are elevated, whereas TIBC and transferrin fall in the normal reference range. In younger patients, symptoms may not be seen and blood values may not be elevated. Serum ferritin levels greater than 200 ng per ml for women and 300 ng per ml for men, and transferrin saturation levels greater than 45% are indicative of HH. Genetic testing would be appropriate for these individuals to establish if they possess the mutations, which are present in 80 to 95% of patients with HH, but this testing is expensive and should be ordered judiciously. The laboratory is critical in the diagnosis of HH, and its value is in providing definitive data for this crucial diagnosis cannot be underestimated. Treatment for hereditary hemochromatosis. Untreated HH can be fatal, and advanced iron overload frequently leads to liver cancer. The treatment of choice for individuals with a diagnosis of HH is aggressive therapeutic phlebotomy or bloodletting. The goal of this procedure is to reduce the serum ferritin level to less than 10 micrograms per deciliter and keep the patient's hematocrit at around 35%. For most patients, 1 or 2 phlebotomies are performed per week as long as the patient can tolerate the procedure. When the patient's serum ferritin has returned to near normal, phlebotomies are performed 3 or 4 times a year to keep the serum ferritin in range. Symptoms lessen and in some cases disappear completely when the iron level is reduced. Excess iron depresses the immune system, and it has been suggested that iron overload causes a significant amount of diabetes. For patients who cannot tolerate phlebotomies or are unwilling to go through the procedure, deferoxamine or desferal, an iron chelating agent, can be used. In this procedure, a dose of desferal is matched to body weight and delivered through a continuous 12 to 16-hour infusion pump. Patients usually use a subcutaneous injection site for infusion and infuse during the nighttime hours. Excess iron is chelated and then excreted in the urine. Infusion sites must be rotated often to avoid infections and irritation. Patients who are non-compliant in ridding themselves of iron through either phlebotomy or desferal significantly shorten their lifespan. Early diagnosis of HH can easily be accomplished by adding blood tests such as serum ferritin and transferrin saturation to the menu of tests offered during yearly physical examinations. The medical community is slowly becoming aware of this silent killer as individual consumers become more knowledgeable about this disease and as organizations such as the Iron Overload Disease Association become more aggressive in outreach and education. The complications of HH are preventable, but the efforts of many individuals, nutritionists, physicians, laboratory personnel, and patients are needed to raise awareness and expand educational outreach. Thalassemia syndromes. Relatively few individuals develop severe forms of thalassemia, but those who do face a lifetime of transfusions and medical management of multi-organ problems. The thalassemic gene is ubiquitous, yet it has a particular penetration in Mediterranean areas and in Middle Eastern, North African, Indian, Asian, and Caribbean populations bordering the seas. More cases are being seen and treated in the United States as more diverse populations enter the country. Lab professionals seem to be more aware of the possibility of thalassemic conditions when a patient presents with a microcytic process yet normal iron status. Physicians and medical students, interns, and residents often fail to consider the thalassemias as a reason for a microcytic process, most likely as a result of lack of in-depth training or exposure. A respectful relationship between the laboratory and medical staff can be tremendously helpful in diagnosing and treating new cases of thalassemia. Pathophysiology of thalassemias. In contrast to other microcytic processes discussed, the thalassemias have nothing to do with iron. The thalassemias are globin chain disorders that result from the lack of production of alpha or beta globin chains. The thalassemias are defects of hemoglobin synthesis. Failure to synthesize either the alpha or beta chain impairs production of the normal physiologic adult hemoglobin. The construction of each of these normal hemoglobins depends on alpha and beta chains being synthesized as part of their normal tetramer. When this synthesis is impaired, hemoglobins form with unbalanced chain production that negatively affects the lifespan of the red blood cell. Additionally, an anemia develops with microcytic cells. Many other red blood cells will have abnormal morphologies, and there are multi-organ complications. There are two major types of thalassemias: alpha thalassemia and beta thalassemia. Put simply, the alpha thalassemias result from alpha gene deletions. Each individual inherits 4 alpha genes, 2 maternal and 2 paternal. Each of the 4 clinical presentations of alpha thalassemia results from the deletion of one or more of the alpha genes. The beta thalassemias revolve around the inheritance of a defective beta gene, either from one parent heterozygously or from both parents homozygously. To date, 200 beta gene mutations have been described, and these mutations have been broadly divided into the B0 or B+ gene. In B0 individuals, there's a complete lack of synthesis in the beta chain, and in B+ individuals, a limited amount of beta chain is synthesized. Both of these mutations affect specific populations. On the molecular level, beta chain defects result from faulty transcription of messenger RNA. Alpha thalassemia. The alpha thalassemias have high incidence in Asian populations. They also occur in Saudi Arabian and Filipino populations. The alpha chain is the crucial building block for construction of all normal adult physiologic hemoglobins, because each adult hemoglobin depends on the production of the alpha chain. The alpha chain is also crucial in the development of fetal hemoglobin. Without alpha chain development, hemoglobin F does not form. Clinical conditions of alpha thalassemia. There are 4 clinical states of alpha thalassemia that are related to the number of alpha genes deleted. The most severe state is Barrett's hydrops fetalis, which is characterized by a total absence of alpha chain synthesis. No hemoglobin A or F is formed, only hemoglobin Barrett's, which is a high oxygen affinity hemoglobin. Because this hemoglobin is an abnormal tetramer and oxygen-loving, it holds onto oxygen and resists delivering oxygen to the tissues. The anemia that develops is severe and usually leads to stillbirth or spontaneous abortion. Hemoglobin H disease is the next most severe condition. There is only one functional alpha gene. The other 3 genes are deleted. Little hemoglobin A is produced. Instead, a new hemoglobin H is formed, which is also a fairly unstable tetramer and represents 5 to 40% on alkaline electrophoresis. Hemoglobin levels are less than 10 grams per dl, and reticulocyte counts are 5 to 10%. Microcytosis and hypochromia are observed in the peripheral smear with red blood cell fragments. An unusual inclusion, hemoglobin H inclusion, is formed. On supravital staining with brilliant crescel blue or crystal violet, this inclusion looks like a pitted golf ball. In the peripheral circulation, hemoglobin H is usually pitted from the red blood cell by the spleen, leaving the cell more fragile and less elastic with a shortened lifespan. Individuals with hemoglobin H disease have lifelong anemia with variable splenomegaly and bone changes. The final 2 clinical conditions are less severe: the 2 gene deletion state, alpha thalassemia trait, and the 1 gene deletion state, the silent carrier. An individual with the alpha thalassemia trait possesses only 2 viable hemoglobin A genes and may have only mild anemia with many microcytic hyperchromic cells. Some hemoglobin Barrett's is formed. A silent carrier is hematologically normal or slightly microcytic, and the patient may be unaware of his or her alpha gene status. Diagnosis in patients from both of these alpha thalassemia subsets, alpha thalassemia trait and silent carrier, may be difficult. However, the presence of elliptocytes and target cells in peripheral smears can have a high predictive value if smears are carefully reviewed for these findings. Diagnosis and treatment. If the most severe alpha thalassemia condition is suspected, especially in pregnancy, amniocentesis fluid or chronic villi sampling may be obtained and examined for the presence of alpha genes through molecular diagnostic procedures. In the case of Bart's hydrops fetalis, most pregnancies are terminated or severely edematous fetuses that are not viable are delivered. Cord blood is usually tested for hemoglobin electrophoresis, which usually shows a high percentage of hemoglobin Barts. Genetic counseling is strongly advised for these individuals and for individuals in high-risk ethnic groups. Hemoglobin H may be suspected if CBC shows a slightly elevated red blood cell combined with extremely low MCV, and RDW results that are extremely elevated, owing to the misshapen red blood cells and fragments compared with the more homogeneous microcytic hypochromic population seen in IDA. Although hemoglobin H may be present at 5 to 40% failure to show an abnormal hemoglobin band by electrophoresis should not eliminate suspicion. Hemoglobin H, a fast-moving hemoglobin on alkaline electrophoresis, may be missed by traditional methods. The final two conditions, alpha thalassemia trait and the silent carrier condition, may not be recognized on peripheral smear analysis because their hematologic pictures are not that abnormal. Treatment for hemoglobin H disease is supportive, and transfusions are given only if necessary. Iron deficiency must be eliminated as a reason for the microcytic indices so that the patient is not given iron unnecessarily. Beta thalassemia major, Cooley's anemia, and Mediterranean anemia. Beta thalassemia major is an inherited blood disorder that affects millions of individuals worldwide. In the United States, more than 2 million individuals are carriers of this thalassemia trait, often resulting in disease presentation owing to significant penetrance of the gene. In beta thalassemia major, little or no beta chain is synthesized. Consequently, no or very little hemoglobin A is synthesized. This condition results from a union between two carriers. The Mendelian genetics indicate a 1 in 4 chance of producing a severely affected individual, whereas other offspring may be carriers. Beta thalassemia major is a serious genetic blood disorder affecting multiple organs, quality of life, and longevity. Most infants born with thalassemia major are not ill for the first 6 months because fetal hemoglobin is the majority hemoglobin at birth. In the normal sequence of events, gamma chains are silenced and beta chains increase, forming hemoglobin A between 3 and 6 months. In thalassemia major, because there are no beta chains to combine with the alpha chains, there is an imbalance of alpha chains. Alpha chains precipitate inside the red blood cell, causing a markedly decreased lifespan of 7 to 22 days. Between 2 and 4 years of age, most young children with beta thalassemia major fail to thrive and have irritability, enlarged spleen, symptoms of anemia, jaundice, and a transfusion requirement. Living with thalassemia major. Patients and families with thalassemia major balance multiple health issues on a daily basis as they struggle to maintain a normal life. Medical management of this disease is continuous, frustrating, and disruptive for children who have the disease and parents who are caregivers and carriers. Severe anemia underlies most of the other complications. Although variable, hemoglobin values are often 6 to 9 grams per dl, about 1/2 the normal level. The patient's peripheral smear shows a severe microcytic hyperchromic process with a high number of nucleated red blood cells, marked polychromasia, and a high degree of red blood cell morphology. Because this chronic anemia state has led to chronic overexpansion of the capable bone marrow, where the bone marrow increases its output to 20 times, the quality of bone that is laid down is thin and fragile. Pathologic fractures and bony changes in the facial structure, or thalassemic fasces, and skull are normally seen and given a thalassemic individual a strange appearance. Bossing, or protrusion, of the skull is prominent, as the orthodontic misalignment. The spleen reaches enormous proportions because abnormal red blood cells have been harbored and sequestered on a daily basis. Enlarged spleens cause excessive hemolysis and discomfort. Many patients have splenectomies, and the surgery ameliorates some of the anemia issues. Splenectomy presents the patient with other challenges, however, because this procedure harbors consequences. Iron overload is a concern for patients with beta thalassemia major. These patients absorb more iron through their diet as their bodies try to accommodate for increased erythropoiesis. In addition, they accumulate iron from transfused packed red blood cells, which contain 200 milligrams of iron. Patients with thalassemia major in the United States have an average transfusion regimen of blood once every 2 to 5 weeks, so iron accumulation is expected and must be medically monitored and managed. Treating and managing thalassemia major. Patients with thalassemia major are on either a low transfusion or high transfusion protocol. A low transfusion protocol treats the patient symptomatically, administering transfusion when symptoms warrant. A high transfusion protocol aims to keep the patient's hemoglobin level close to 10 grams per dl, and the patient is transfused every 2 to 5 weeks. There are good arguments for both protocols, bearing in mind that transfusion exposes the individual not only to excess iron, but also to foreign red blood cell antigens and other bloodborne diseases. A high transfusion protocol gives the patient the best hope for a normal quality of life by increasing his or her hemoglobin and providing better bone quality, better growth, less iron, and near normal spleen size. Iron overload looms as a major outcome of the high transfusion protocol, however, and is the major focus of clinical management. Patients must be assessed for liver, pancreatic, endocrine, and cardiac iron. Although non-invasive procedures are available, they are specialized and not available at every clinical facility. Iron overload poses significant risk to cardiac function and leads to hepatic and endocrine complications. Iron chelation is recommended when the serum ferritin level reaches about 1,000 micrograms per liter. This usually correlates with about 10 to 20 transfusions from the onset of diagnosis. This procedure for chelation with desferal was explained earlier in this chapter. Compliance is crucial in patients with thalassemia major and becomes difficult to maintain as the patient moves from childhood to adolescence and becomes less willing to be hooked up to the infusion pump. 2 oral chelating products with U.S. Food and Drug Administration approval are available. Oral deferocerox, which became available in 2005, and deferiprone, which became available in 2011. Most patients who undergo long-term transfusion are advised to begin chelation therapy within 2 years of continuous transfusion. Despite compliance with chelation therapy, cardiac complications continue to be the leading cause of death in patients with thalassemia major. Therapeutic modalities for patients with severe thalassemia include bone marrow transplantation and stem cell transplantation. For patients considering bone marrow transplantation, finding a compatible donor is the necessary first step. If this can be accomplished, bone marrow transplant should be considered early, before the patient develops too many complications of thalassemia. The transplant procedure itself is rigorous and risky. Stem cell transplantation, although a viable alternative, takes much forethought and often is limited by the fact that stem cells have not been collected from the umbilical cord after delivery. Thalassemia intermedia and beta thalassemia trait. Individuals with thalassemia intermedia are not well-defined subset of patients with thalassemia major. As a clinical group, they develop problems later in life than patients with thalassemia major, and they may not need transfusions. They develop larger spleens, but their transfusion requirements, if present, are less frequent. Bone changes may be present, but they're mild. Patients with thalassemia intermedia may require iron depletion with desferal therapy, but much less frequently than patients with thalassemia major. Beta thalassemia trait is the heterozygous condition in which only one abnormal beta gene is inherited from the parent. This condition mimics IDA with patients presenting microcytic hypochromic indices and moderately low hemoglobin and hematocrit values. Beta thalassemia minor has often been confused with IDA, but close examination of the CBC shows an increased RBC. Above all other values, the increased RBC is significant in this condition because it represents that the bone marrow is compensating for having only one half the complement of beta chains. Because a moderate anemia is present in this condition, there is an increasing production of EPO and therefore an increased RBC. This change, although subtle, is often unrecognized by clinicians, and for this reason, many patients with beta thalassemia minor have been put on iron protocols that offer no therapeutic value. Iron is not the problem in beta thalassemia minor. Although a therapeutic trial of iron may not harm the patient in the long run, it's not a good medical management. Patients who have microcytic indices may represent the largest number of patients with anemia. A careful diagnosis that considers broader possibilities for a microcytic presentation is in the best interest of the patient and the healthcare system as a whole. Diagnostic clues for thalassemic conditions. If you suspect 2 or 3 gene deletion alpha thalassemic state, MCV is much lower than iron deficiency anemia, RDW much more severe in alpha thalassemias. If you suspect silent carrier alpha thalassemic state, the MCV in normal or low normal range, and the presence of elliptocytes on the smear is an indicator. If you suspect beta thalassemia major state, the MCV would be low and high numbers of nucleated red blood cells on the smear, presence of targets, fragments on smear, macrocytosis and hypochromia, hemoglobin F, major hemoglobin on electrophoresis. If you suspect beta thalassemia minor state, the MCV is lower than in iron deficiency anemia, the RBCs are elevated, macrocytosis and hypochromia, you may see basophilic stippling and targets on the smear, and hemoglobin A2 is elevated. Summary points. An anemia classified as microcytic hypochromic means that there is decreased MCV and decreased MCHC. The most common microcytic anemias are IDA, sideroblastic anemias, HH, and anemia of chronic disease. Iron is ingested, absorbed from the duodenum and jejunum, and then moved from the bone marrow by transferrin, the transport protein. Individuals with IDA experience symptoms of anemia and perhaps cheilitis, koilonychia, or pica. Individuals with iron deficiency have decreased serum iron and serum ferritin and increased TIBC. Anemia of chronic disease or anemia of inflammation is one of the most common anemias in the hospital population. HH is an inherited iron-loading anemia. Multiple organs are affected in HH because individuals with HH have been iron-loading for decades. Serum iron and serum ferritin are high in HH. Therapeutic phlebotomy is the therapy of choice for HH. The thalassemia syndromes are globin chain synthetic defects. There are 4 clinical conditions of alpha thalassemia, each caused by gene deletions. Beta thalassemia major is the most severe of the beta thalassemic conditions. Individuals with beta thalassemia major have severe anemia, splenomegaly, and thalassemic phases. The majority hemoglobin in beta thalassemic major is hemoglobin F. Beta thalassemia major is similar to IDA with the exception of an elevated red blood cell and an elevated hemoglobin A2. Review questions. The morphologic classification of anemias is based on the red blood cell indices. Koilonychia is one of the specific symptoms for IDA. Serum ferritin would be abnormal through each stage of iron deficiency. A patient presents with a microcytic hypochromic anemia with ragged-looking red blood cells in the peripheral smear and a high reticulocyte count. A brilliant crescent blue preparation reveals inclusions that look like pitted golf balls. These inclusions are suggestive of hemoglobin H disease. The most cost-effective therapy for a patient with hereditary hemochromatosis is therapeutic phlebotomy. 2 sets of laboratory data that can distinguish IDA from beta thalassemic trait are serum iron and RBC. The majority hemoglobin in thalassemia major is hemoglobin F. Of the 4 clinical states of alpha thalassemia, Bart's hydrops fetalis is incompatible with life. Hemoglobin H has the chemical conformation beta 4. Although there are many complications in individuals with thalassemia major, the leading cause of death is cardiac complications.